Good evening. I'm Kerry Diamond with Sunnybrook's Board of Directors, and it's my pleasure to welcome you to our virtual speaker series this evening. February is Heart Month, a time to focus on the importance of what we can do to protect our hearts and cut down on the risks that can impact our cardiovascular health. While heart health is important for everyone to think about, this evening's focus will be on women. According to the Heart and Stroke Foundation, most women in Canada have at least one risk factor for heart disease and stroke. The many stages of a woman's life can pose particular challenges and risks due to factors like hormonal changes. This is something you'll be hearing more about from our incredible panel of experts set to speak this evening. Alongside our esteemed panel of presenters, we are very fortunate to have Dr. Harindra Wijeysundera moderating tonight's discussion. Dr. Wijeysundera is Chief of Sunnybrook's Schulich Heart Program. He's an interventional cardiologist with a specific interest in transcatheter aortic valve implementation and coronary total occlusions. Dr. Wijeysundera is also involved in research and has collaborated with multiple decision-making groups to produce policy-relevant research. This is just a snapshot of his biography, and as you can see, we are in very good hands having him moderating tonight's event. Dr. Wijeysundera, it's a pleasure to introduce you, and I'll now pass the microphone and the event over to you.
Thanks very much, Kerry, for that very kind introduction and kicking us off tonight. And good evening to all of you who are joining us remotely. This is really a particularly special event for me. I really enjoy these during our speaker series during the February Heart Month. And this one is the first that I've been part of that's going to focus on women's heart health. We're very lucky that we have a great lineup of speakers to address different aspects of this really critically important issue. Dr. Mina Madan will be kicking off the talks with her presentation on heart attacks in younger women in Ontario. And then Jennifer Amadio will be talking about managing cardiac disease in the pregnant patient. And then finally, Dr. Barbara Doumouras will be presenting on what women need to understand about heart and cancer, two really large and important programs at Sunnybrook. We'll make sure to set some time aside at the end of the evening for you to ask our panel of speakers some questions. Thank you to all of you who have already submitted a question online. You're certainly free to send your questions while the presentations are happening, and I will review them and pose them to our panel. We've already had quite a few questions sent in to us, so we may not get to everyone. What we'll do our very best with the time that we have available. So with that, I'm going to begin with the lectures, and I'd like to introduce you to our first speaker. So Dr. Mina Madan is an interventional cardiologist here in the Schulich Heart Program. She is the medical director of our cath lab and has been really a wonderful colleague for, I would say, almost 20 years now. So it's a real pleasure for her to be here and speak to you on something that is very dear to her heart, that she has worked extremely hard on and has really become a national and international leader in this. So she's going to be presenting on the victories, opportunities, and challenges of heart attack care for younger women in Ontario. So with that, I'll pass the mic over to you, Mina.
Okay, thank you everyone and good evening. I'm going to try and share my screen, and I hope that you all can see that. Harindra, if you would just tell me if it's advancing for you. How's that?
It's not on the presentation mode.
Yeah,
right now.
okay, that's what I thought would happen. It's just 1 second. I'll try it again. Sure, here it is. Thank you very much. How's that?
Yep.
Okay, great. So good evening, everyone. Thank you for the kind introduction. I'm really excited to be a part of this event this evening. I wanted to use the time I have with you this evening to highlight some research that I've been doing on outcomes of younger women after heart attacks in Ontario, and then also tell you about something I'm very passionate about, which is a very special kind of heart attack called SCAD that I have spoken on, I think once previously at this type of session, and give you a progress update on my work in the Sunnybrook SCAD clinic. In the last decade, there's been increasing focus on heart disease in younger women, and especially heart attacks in younger women. And it's not unusual to see younger women having heart attacks. So when we think of causes for heart attacks or myocardial infarction in women, there's a lot more on the menu to choose from in women. So atherosclerosis, by and large, is the much more common reason to have a heart attack, so coronary artery disease. But there are many other causes of heart attacks in women especially, such as spasm of the arteries, a certain kind of muscle disease called like a stress cardiomyopathy. It has a fancy name. Small vessel disease in the heart muscle, blood clots flying over to the coronary arteries and obstructing blood flow. And this newer diagnosis that's become more prominent in the last 5 years, which I will touch on later in our talk tonight. So my colleagues, including Dr. Wijeysundera, we had the chance to publish the lead article in the Canadian Journal of Cardiology in November of last year. And this was a study looking at clinical outcomes of younger women who were hospitalized with a heart attack in Ontario. And the background for this work was that there are approximately 60,000 Canadians admitted each year with a heart attack. And study after study has shown that women are tending to have worse outcomes than men. And the older studies might not be so representative anymore because we've gotten a lot better at heart attack care in Ontario. And very few studies are looking at younger women. And so we wanted to look at younger women specifically in a contemporary period. We do know that younger women usually have more risk factors and more diseases than younger men when they present with heart attack, that they experience more delays in their diagnosis, and that they're often referred less often for angiography or heart surgery after heart attacks, and that some studies have shown that younger women have higher death rates than men, and even compared to older women. There have been a lot of vigorous education campaigns over the years trying to educate the public to take action about their heart, and especially invigorate women to take action about their heart health. And despite these efforts, there's concerns that the improvement that we're seeing in clinical outcomes is not being realized among younger women. So this is just an example of some of the media campaigns. Time magazine had this media cover. It's going back over 20 years ago now. And the Go Red for Women campaign in the American Heart Association is a very prominent one that raises awareness about women and heart disease. And in Canada, we have the Her Heart Matters movement as well. So our research question was, does disparity continue to exist in processes of care and outcomes for younger women after heart attacks in Ontario? And we looked at a 10-year period from 2009 to 2019. And we studied 38,000 hospitalizations in patients aged 18 to 55, of which 20% were women. We compared the coexisting illnesses that these patients had. We looked at their coronary angiograms, their rates of getting angioplasty and bypass surgery, and our main outcomes were focused on death rates and how often patients were readmitted for another heart attack, heart failure, or stroke. And this is a busy slide, but I just wanted to point out a few important points for this audience. So the average age was just under 49 years in our group, and most patients stayed about 4 days in hospital. In terms of diabetes and high blood pressure, these risk factors were more common among women than younger men. And younger men had more high cholesterol levels and more incidence of smoking. When we look at other diseases such as prior heart attacks, kidney disease, heart failure, lung disease, cancer, and prior strokes, they were all more common among women who presented at a younger age with heart attack. If we do a deeper dive at the coronary angiograms of these patients, there are two really important things on this slide, and they're here. The rate of non-obstructive or mildly diseased arteries was much higher, 2.5 times higher among women than men. And the finding of normal coronary arteries at angiography was also about 2.5 times higher or 3 times higher among women than men. And that might explain why women are referred less often for invasive revascularization, like for angioplasty or surgery, because they may have more mild disease or no disease when we look at their coronary arteries. And maybe it's because of all those other types of causes for heart attack that are more prevalent in women. On this slide, we can see that angiogram rates were quite high in both men and women in Ontario. Rates of echocardiogram during the hospitalization also quite high. Cardiology follow-up and family physician follow-up after heart attack was very high. And I already talked about the angioplasty rates being lower among women. When we looked at trends in risk factors, here I've shown diabetes and high blood pressure, cholesterol, and smoking. And the main points on this slide are that the rate of diabetes grew by 10% over 10 years in women and only by 4% among men. Rates of high blood pressure and high cholesterol were quite high in this younger age group. And although smoking fell significantly in both men and women over this study period, the rates are quite high, 50% falling to about 40%. The general population only has smoking rates of about 17%. So this is a population that's having quite a high burden of risk factors. When we look at outcomes, we can see that mortality rates were similar among men and women at 1 year after the heart attack. And we also see that women more often had readmissions for another heart attack, for heart failure, for stroke, and that even all-cause readmissions, so from non-cardiovascular causes, were also higher among women. So there's a good news, bad news story here with this project. The first thing is that these gender-based care gaps that previous research has shown are closing in Ontario, and the death rates are similar among men and women. And by 2018, the use of angiograms was really pretty universal across the board. And there are high levels of primary care and specialist care after heart attacks for these younger patients. The bad news is, though, that the rehospitalization rates, whether it's for cardiac causes or non-cardiac causes, was much higher among women. And there's really the burden of risk factors is very high in this population. So we do need intensive primary prevention strategies that are directed at women. One thing we gained greater understanding, though, in this study is that we found more often mildly diseased vessels or even normal coronary arteries among women. So that's kind of an aha moment, because we now could understand maybe why lower rates of angioplasty or surgery might be appropriate in this younger age group. And there's increasing recognition of these alternate ways for younger women to have heart attacks. So maybe it wasn't really a disparity at all. It could make sense. So with that, I do want to turn the rest of my time with you all to a topic of spontaneous coronary artery dissection, which is an increasingly recognized cause for heart attacks, not only in younger women, but also across the age spectrum. And indeed, patients with SCAD could be your mom, your sister, your neighbor. It's an important newer cause for heart attack, mainly in women. That's important to know about. And I'll open that discussion with a case because I realize that not everybody in the audience may be familiar with this type of problem. This is a patient of mine who's 50 years old. She, out of the blue, experienced chest pain, called EMS by dialing 911. She had a history of high blood pressure and smoking. The paramedics arrived at her home, and a heart attack was diagnosed on her ECG. And the paramedics started to transport her to the nearest hospital, and she had a sudden cardiac arrest in front of them. She was successfully defibrillated, and they rushed her to the nearest center that could do an angiogram. In the angiogram, there were a few interesting findings, and I've shown her angiogram here. The angiogram showed smooth coronary arteries and twisty arteries. And you can see the twistiness shown by these asterisks here, and an area of narrowing in this coronary artery at this point. This black line here is not as fat as it is here compared to this area of narrowing. And here's another look at it here. The doctor decided to look closer inside the artery by imaging the artery using optical coherence tomography. And you can see here, this is the opening of the artery in cross section. This is the imaging catheter. Here, the artery looks fairly normal, but here the opening is compressed by blood in the wall of the artery. And also at point C here, it's also quite compressed. So this is SCAD. This is spontaneous coronary artery dissection in this patient. And the patient was pain-free at the time of the angiogram. The artery had brisk flow. The doctor made a good decision not to place a stent. This patient stayed in hospital for 7 days and did well and went home. But 2 weeks later came back with chest pain. And because of the previous heart attack, her doctors decided to repeat the angiogram. And 2 weeks later, you can see that the artery has returned to a normal appearance. So these arteries do heal up by themselves. And we did publish this paper in the Canadian Medical Association Journal to educate the medical community in Canada and raise awareness for this not so unusual cause of heart attack in younger women. So SCAD was previously quite underdiagnosed, but I think we are gradually improving on this front. It predominantly affects women in their 30s to 50s, but 10 to 15% are men. And often there's not many cardiac risk factors. It presents as small, medium, or large-sized heart attacks and even cardiac arrest. And it's not so rare. Sometimes it can be seen in up to a quarter or third of cases of younger women with heart attacks. So it is a spontaneous, non-traumatic separation of the coronary artery wall by blood in the wall of the artery. The coronary arteries are characterized as being smooth and often quite normal looking, but they do have these zigzag kind of loops in them or corkscrew tortuosity. And I can show you here on a cartoon, this is a normal artery. Here is the presence of a tear in the lining of the artery wall, allowing blood to get into the artery. In this panel, we can see that a spontaneous bleed in the artery wall allows blood to get in and compress the opening of the artery from the outside in. And it's quite different than cholesterol plaque that accumulates over many, many years in the artery wall. And there are often some predisposing conditions. We see often in patients either fibromuscular dysplasia as an associated condition, or often these types of heart attacks might be pregnancy related. There are often associated stress factors like intense, unusual forms of exercise or intense emotional stress. How patients present in the emergency room is completely identical to a traditional heart attack, with chest pain radiating down the arm, nausea, vomiting. You cannot distinguish it in the emergency room. It's really a diagnosis in the cath lab made on the angiogram, and the appearance of the angiogram in a patient who's had a heart attack at a younger age without much in the way of risk factors, and often keeps company with smooth, twisty arteries. So it's really based on pattern recognition. Now, this condition, fibromuscular dysplasia, results in collagen or fibrous tissue being deposited into the walls of arteries and is associated with the formation of aneurysms, irregular arteries, and twisty arteries. And just some examples of that. This is the pattern of a loop in a coronary artery and twisty artery shown here. And if we look carefully, we can find this in most patients with SCAD. Here are kind of irregular contour in the patient's kidney arteries on both sides. You can see that here. And here we see fibromuscular dysplasia of quite an extreme sort in a kidney artery, this kind of lumpy, bumpy beads on a string pattern. We can also see it in carotid arteries here. But SCAD can heal, and it can heal without intervening. And that's what makes it different from a traditional heart attack. Here's just an example of that. This patient has compression of an artery feeding the front wall of their heart. And 8 weeks later, the vessel has returned to normal because that bruise in the wall of the artery resorbs. Here is another example of a patient with that twisty right coronary artery who presented with a heart attack involving the front wall of her heart. And here is the segment of SCAD. 8 weeks later, the vessel is healed, and stents are usually not required for these patients. In fact, stents can actually sometimes squeeze the blood collection both downstream and upstream, creating a very difficult mess to try and reestablish blood flow to these patients' arteries. So we really try to avoid stenting in these patients. Lastly, I wanted to give you an update about the SCAD clinic. I started this clinic back in 2019 to try and improve a lot of care gaps that I saw in this patient population. And to date, we've seen about 200 patients in the clinic. And we are certainly not the only SCAD clinic in the Toronto area, but perhaps maybe the only one who raised a flag and advertised about this. In the SCAD clinic, we educate patients about the best medications for their condition. We screen them for fibromuscular dysplasia. We encourage them to join cardiac rehab programs, and we try to get them into research programs. So we participated, just as an example, over 4 years in the Canadian SCAD study, and we enrolled 750 patients from centers across Canada, 22 sites. And we found that conservative therapy in our 750 patient sample was followed for over 85% of the cases. And the 30-day survival with that approach was nearly 100%. When angioplasty was required, it was only successful or partially successful for the most patients. And SCAD could recur in the first 30 days, but fortunately not in very many. And patients with peripartum SCAD or an underlying connective tissue disorder had worse outcomes at 30 days. So in the fall of last year, we published our 3-year results of this project. And in patients at 3 years who had remained, most of them remained on aspirin and a type of blood pressure lowering medication called beta blockers, the recurrence rates were very low, only under 2.5%. This is big news for the SCAD population because we used to think recurrence rates were as high as 10 to 30%. We also saw that persistent chest pain syndromes were really common in this population. In fact, there were ED visits and readmissions to hospital. And that kind of ties in with the findings of the last study that I showed you, that I started the talk with. I've also found out that it really takes a village to take care of these patients, and I've engaged with many collaborators shown on this slide to get the best care for these patients. Finally, we started the clinic, and in last spring, we were able to publish with the help of a patient and family education award and the help of Sunnybrook donors. We were able to put out an education guide called the SCAD Patient Guide. And this is the website shown here. It's free, it's for everyone, even physicians, to learn more about SCAD and how to take care of patients properly. And we've had great response from across the country. And also we've been contacted by the Israeli Heart Society, physicians in South America, Scandinavia, even asking to translate the guide into other languages. So that's been a really, really worthwhile effort for us. So I want to conclude by saying that the victories I've seen in my work in the past year have been that younger Ontarians are receiving very high quality care after acute myocardial infarction. Rates of primary care and specialist care are very high, and the recurrence rates for the SCAD population are much lower than we previously thought. I think there are some opportunities, though, and for traditional heart disease, these risk factors are really on the rise, especially diabetes, obesity, smoking. The rates are too high in younger populations, so I think that renewed efforts at public education are warranted. And I put if you grew up in the 70s, you probably saw participation badges that we used to try and earn at school, and I think we need some kind of participation campaign again. So the challenges that I see, though, are that younger women with heart attacks from all causes are a very vulnerable group, and they have increased rates of readmission after heart attacks. And I think that we really need to rethink this. How can we support these patients better? More frequent follow-ups, earlier follow-ups, leaning on nurse practitioners to see these patients, maybe more social supports will help. So certainly a lot more work to do. So I really, really thank you, Harindra, for the opportunity to get involved tonight, and I hope that's been helpful to everyone.
Thanks very much, Mina. What a great title, the victories, opportunities, and challenges. And I love your last slide, how you laid those out. I also like how you show so much of what the Schulich program is about, using data to look at things at a 40,000-foot level, but also the many types of imaging to help diagnose the individual patient better. I think those pictures you had of OCT really highlighted that. So it's my pleasure to introduce our next presenter, Dr. Jennifer Amadio. She wears many hats in our program. She is an advanced heart function physician, so she takes care of patients who have weak hearts. She is an expert in cardiac imaging. And in addition, she is the lead of our Cardio-Obstetrics program. So she carries three really important hats. And she's here today to present with a talk that's entitled Double the Trouble, Managing Cardiac Disease in the Pregnant Patient. Over to you, Jennifer.
Thank you so much. And thank you everyone for the opportunity to present today. Yes, thank you. So Double the Trouble, Managing Cardiac Disease in the Pregnant Patient. So this is a new program here at Sunnybrook that we're developing in cardio-obstetrics. It's an area that's really been growing in recognition and in popularity kind of across the nation. And so I'm happy to share some updates with you today. I don't have any relevant disclosures. And so today, for the outline of this short talk, we'll discuss a little bit about pregnancy and the changes that occurred during that time and what lifestyle modifications many women undergo, about the cardio-obstetrics and the purpose of the cardio-obstetrics clinic, who, what, and why, cardiac risk stratification for women undergoing pregnancy, and then postpartum care. So the physiologic changes during pregnancy, there are many changes that women undergo throughout the stages of their pregnancy that include having an increased blood volume, increasing their heart rate during their pregnancy, having a higher cardiac output, which is the amount of blood that the heart can pump throughout the body, can increase by up to 40% by the late second or early third trimester. And women also have reduced systemic vascular resistance, which can lead to lower blood pressure and also hypercoagulability, or an increase in the body's ability to make blood clots, which can be sometimes a problem for women having blood clots. And so we can follow the trends of these physiologic parameters. And in women that have underlying heart disease or heart dysfunction, this overload on this body system can sometimes lead to problems or manifest in certain cardiac diseases that we can follow. And the symptoms can be quite blended or hard to distinguish between normal pregnancy or is this actually a heart problem. And so that's what the specialists here can help to determine. And so some people say that the physiologic changes that happen during pregnancy are a stress test whereby a subclinical cardiovascular or heart disease can be unmasked by these changes that the body goes through with this increased blood volume and increased cardiac output. It can really help to unmask these problems. So when deciding to become pregnant, often women will undergo pre-pregnancy counseling versus prevention. So depending on what the underlying heart disease is, some women may need to undergo certain monitoring or certain changes or heart tests before becoming pregnant. And so the team of the obstetrician and cardiologist can help you to evaluate these risks. In very rare cases, sometimes pregnancy is not recommended and then a decision would be made together. But ultimately, our goal is to try to optimize women medically to make the pregnancy as safe as possible for you. So to help to identify your pre-existing illnesses and titrate those medications, like women with thyroid dysfunction, for example, or diabetes, elevated body mass index. These are all things where we can help to optimize medications to make pregnancy as safe as possible. Often we add on medications or supplements. Many of you may remember taking folic acid in the period before conception to help to reduce neural tube defects in the infant. And we can also have prescription medications that many women that have pre-existing heart disease that are on that are really good for your heart, but may not be good for your baby. And so it's important to change those medicines or switch these medications that we call teratogens, or that can cause birth defects, to make the pregnancy as safe as possible for both of you. So it really can be double the trouble, and it's important to keep both parties in mind. So the American Heart Association has recently expanded their Life's Essential 8, which are the 8 main factors that are modifiable risk factors for women and their cardiovascular health. And these include having a healthy diet, increasing your physical activity, not smoking, having a healthy body mass index, having a good control over your blood pressure, monitoring your lipids, which is a fancy word for cholesterol, and monitoring your blood sugar. And then they've just added an 8th component, which is sleep health. So these 8 components together can all have a modifiable impact on your overall cardiovascular disease risk. And this is important in terms of planning and reducing your risk of cardiovascular disease going forward. So what is Cardio-Obstetrics and what can the team here do? So this team is comprised of many physicians and allied health team members, including your obstetrician or maternal fetal medicine specialist, your cardiologist or heart specialist, anesthesia, often pharmacy and nursing and social worker, all work together in this pre-pregnancy counseling phase, monitoring women during their pregnancy, helping to plan a safe delivery, and then following the women postpartum after they've delivered their baby. And so there'll be multiple encounters throughout the course of your pregnancy in those women that are at higher risk or require specialized cardiac care with the coordination of this team. And our team here at Sunnybrook will involve many of those individuals. And recently we've had the opportunity to expand our program to include remote monitoring of the heart rate or telemetry, which expands our ability to keep the mothers here with their babies. And so it's important to have cardio-obstetrics for those women that have increased complexity of their disease. So women that have pre-existing congenital heart disease or a heart defect that they were born with are now surviving longer, surviving till adulthood. Before, in the past, many years ago, these women or children would die in childhood. And now with modern medicine and surgeries, women are living longer and then surviving on to have their own children. And so this is kind of a new population that we're now having to support through this period. Also, many women, for various social factors, are at an older age when they conceive their first child. Some women have high blood pressure or diabetes, or can have elevated body mass index. And these women are at higher risk of cardiovascular disorders, and so should be monitored more closely in the pregnancy, both for the mother's risk, but also to reduce the risk of the baby of a complication related to these medical illnesses. And all of these factors together can lead to a higher risk of maternal mortality. And so why do we do this? Why is this so important for us? Well, in the United States, nearly 1 in 5 births is actually complicated by an adverse pregnancy outcome related to cardiovascular disease. And this is the leading cause of maternal death or mortality. And this represents over a quarter of patients in their pregnancy-related deaths. Also, they found on their epidemiologic analysis that Black women also have a higher risk compared to white women, up to 3 to 4 times higher. So it's important when we're identifying patients that we don't, identify these races that have been previously quite marginalized or have limited access to care, and help to support them. Over the last 30 years in the United States, the pregnancy-related deaths have actually trended up despite our modern medical care and being able to identify these women earlier. And a similar trend is seen here in Canada. A prospective Canadian study that surveyed 2 main cardio-obstetric centers reported cardiovascular complications as high as 16% of all pregnancies. And of those complications, having heart failure or reduced heart pump function, or arrhythmia, which is an irregular heartbeat, were the most common complications. In fact, maternal mortality was still low, less than 1%, but these complications were prevalent in quite a large proportion of the pregnancies. And heart failure was found to be most common in the 2nd or 3rd trimester, or occurring in the postpartum period, kind of at the time where those peak physiological effects of the increased cardiac output and higher demands on the body occur. 3.5% of all pregnancies were complicated by a serious cardiovascular event, which meant a cardiac death or arrest, which we obviously significantly want to prevent, having heart failure, an irregular heartbeat, or needing an urgent heart intervention. And so what does this mean for women, and how can we better identify them? Many pregnant women will feel short of breath towards the ends of their pregnancy, can develop swollen legs, or can feel very fatigued. And so sometimes the symptoms of heart dysfunction can mimic those symptoms that are just normal in pregnancy. So it's important to see your provider regularly, and for us to be aware that these complications can occur to help link you to the correct team member. So what types of patients will we see? We see those patients that have peripartum cardiomyopathy or weakened hearts related to pregnancy. Those women that have acquired heart diseases like cardiomyopathy or valve disease or heart attack. We see women that have irregular heartbeats, those patients with SCAD, as Dr. Madan mentioned, that can occur in pregnancy, so spontaneous coronary artery dissections or tearing of the artery wall. Those women that can have aortopathy or enlargement of the aorta, the main blood vessel that comes out of the heart and feeds the blood to the body, and congenital patients that have congenital heart disease or are born with a heart defect that need follow-up. And then there are the women that have those cardiac risk factors that we think of when we think of traditional heart attack risk factors like high blood pressure, high cholesterol, and diabetes. And so here at our center, we have cardiologists that specialize in each of these kind of main areas that help us to manage our patients that have had a heart attack, that have weak heart muscle, that have had irregular heartbeats, and have high blood pressure during their pregnancy. And so we can help to manage these patients before, during, and after their pregnancy. And so there are some complications that can occur in pregnancy, and this will also be managed by the cardio-obstetrics team, including tearing of the artery, having a heart attack or stroke, or having heart failure or pump dysfunction, and managing those patients afterwards with visits and follow-up and sometimes medications. So how can we stratify the risk of the patients? Who of these pregnant women are most at risk? So the World Health Organization, or WHO, has created a risk classification that can help us to stratify patients. And there are 4 main categories in this busy slide, but ultimately the patients that are of WHO class 2 to 4 should be followed at a dedicated cardio-obstetrics center. And those women that are in class 4 often have contraindications, or they should not become pregnant because of their risk due to their underlying heart disease. In those patients, maternal cardiac event rates were 40 to 100%, and the risk of maternal death was up to 10%. So it's important to be screened and to talk with your doctor and be optimized as best as possible before considering a pregnancy. Also here in Toronto, Candace Silversides is one of our Toronto cardio-obstetric physicians, developed the CarPreg-2 score through their study, and she's the lead author of Outcomes in Women with Heart Disease. And so we can use the CarPreg-2 score developed here through also in Toronto, to help identify those patients at higher risk of adverse heart events. And so it's a combination of many factors, including important components of your patient history, what we find when we do our physical examination, having a previous history of something like a mechanical heart valve or prior heart attack or coronary artery disease, and then the delivery of care that occurs with your obstetrician. And so patients are given points for the number of these aspects on this score, and a score of greater than 4 indicates a 41% risk of having a primary heart event during the pregnancy. So obviously quite high risk in a way that we can stratify patients. In the CarPreg-2 score, they found that the patients that had irregular heartbeats tended to present earlier on in their pregnancy, whereas those patients that developed more heart pump dysfunction or fluid retention in the lungs and legs developed that kind of towards the end of their pregnancy. And so this can help us to identify these patients as well. Over time, you can see that here in the blue bars between 1994 and 2000, and the red bars represent 2001 to 2014, the percentage of the pregnancies and their complications has started to go down for any cardiac events and maternal cardiac death, as well as those patients that develop pulmonary edema or fluid in the lungs. So we have shown some improvement. However, there's still obviously a lot of work to be done, with almost 15% of the patients having any cardiac event in this study. So what about after your baby is born? The risk factors that occur during your pregnancy are important predictors for future atherosclerotic or plaque buildup in the heart arteries and your overall cardiovascular disease risk. And that's what we want to try to prevent. And so women that have had a history of preeclampsia or eclampsia, that have small for gestational age babies or low birth weight babies when they're born, have a history of gestational diabetes in pregnancy, or have had a preterm delivery, so a baby born before 34 weeks or earlier than 34 weeks, are all at a higher risk of having future cardiac disease. And this can be heart attack, having high blood pressure, or having diabetes in the future, and can also impact future pregnancies, leading to, again, small birth weight babies or preterm labor. And often we think that, oh, the pregnancy is over, and so my risk should go back to normal. But this is not the case, and this is not always communicated to women after they've delivered their babies. The risk remains, and so these women should really be screened after the postpartum period. And this is a real need for our population, to identify those women and do a good risk assessment for coronary artery disease or plaque development. And that's where this particular emphasis comes on the Life's Essential 8, which I talked about before. All of those 8 components that help us to lower our cardiovascular disease risk, and that these women should be counseled about and monitored for. These things like high blood pressure, high cholesterol, high blood sugar, and having a healthy diet and physical activity, and now getting a good night's sleep has been added. So I think early in the postpartum period, that may be harder for some to achieve than others, but over time, to try to get 7 hours or more of a good night's sleep has now been added to this algorithm for your overall health and to improve your heart health. So ultimately, in conclusion, the goals of this program are to have healthy mothers and healthy babies. And we want to try to coordinate your care here at Sunnybrook now that we have built out this program, so that everyone can have their coordinated care here at our center, and to evaluate all aspects of your care to make your pregnancy as safe as possible for you, and to monitor these women in the future to improve their overall heart health, so that they can stay well for their new families. So if you'd like to get more information, the Center for Disease Control has a lot of great resources here, as well as the Mayo Clinic, where I did my training. All have great patient resources where you can get more information. And so thank you very much for the opportunity to speak today, and I'm happy to take any questions later in the session. Thank you.
Thanks very much, Jennifer. I learned a lot, and that was really very informative. And I'm so glad that this program has launched with you joining us. Just a reminder to everyone online to please send us your questions. We should have about 45 minutes at the end of the session to go over all the questions. So now I have the pleasure of introducing our final speaker this evening. So Dr. Barbara Doumouras is a cardiologist and adjunct lecturer with the Schulich Heart Program. She also wears quite a few different hats. She is also an advanced heart failure physician, so she treats patients with weak hearts. She also has expertise in advanced imaging with echocardiography. And she is got expertise in cardio-oncology, which is cardiac manifestations of cancers. And her presentation is going to be on understanding the heart and cancer, what women need to know. Barbara, the floor is yours.
Thank you so much, and thank you everyone for joining us. I'm going to share my slides, and if you can see my slides. Okay, perfect. Okay, so I will be discussing the intersection between the heart and cancer, specifically looking at cancer therapies and their effects on the heart, and with a special focus on the differences between women and men. So in terms of the objectives of this talk, so by the end, we'll have a better understanding of the goals of cardio-oncology, review important highlights from the main guidelines where we are using in order to dictate care for patients, the 2022 European Society of Cardiology ESC guidelines. And finally, learn about sex differences in cardio-oncology and areas of future research focus. And it's definitely an area that is growing in interest, and we will be seeing more studies in the future. So this is a heart talk, but before I get into more of that, I want to go over what is the burden of cancer disease. So this is data taken from the World Health Organization, the WHO, and it looked at 2000 and then in 2019, what were the main causes of death worldwide. So we can see number one worldwide is ischemic heart disease. So Dr. Madan and Dr. Amadio have discussed this, but it's always good to repeat things when we're learning something new. So ischemic heart disease is when we have narrowing or blockages of the arteries, the blood vessels, supplying blood and oxygen to our heart. That can lead to heart attacks, to chest pain or angina, and can lead then to downstream effects where your heart muscle is not pumping properly. So that is the leading cause of death. When you go down to the list of this, you see number 6 that lung cancers are listed there, as well as other respiratory cancers. Altogether, in 2019, there were over 55 million deaths, with these top 10 causes of death accounting for more than 50% of the total causes of death. Again, with heart disease being the most prevalent and also cancers being high up on the list. Now, where does Canada fit in? So this is data from 2020. It's taken from Statistics Canada and also from the Canadian Cancer Society. So we can see here that in Canadians, and this is all ages, and it's also both females and males, although if you take them separately and look at the main causes of death for females and the main causes of death for males, you see a somewhat similar picture. So cancer is the leading cause of death at 28%, and then heart disease in all its forms is 19%. And together, these two make up almost 50% of the leading causes of death for Canadians. And this has been the case from 2016 to 2020 and is the same for both females and males. Now, what is the burden of cancer worldwide, and why is this a major problem? So the most common cancers that are newly diagnosed in patients worldwide are number 1, breast cancer, with the majority of those patients being women, followed by lung, colon, prostate, skin cancer, and then finally stomach. In Canada, we see a similar picture. Again, we're seeing that breast is the most commonly diagnosed cancer. So again, mainly affected by women. Lung, colon, and prostate are also the most common in Canadians as well. Now, in terms of the most common causes of cancer death, the ones that we see are worldwide: lung, colon, liver, stomach, and breast cancer is number 5 on that list. But again, a high burden of disease and areas where intervention is needed. So where does heart health come into all of this, and where is the link between the two? So before I go on, and I know some of this was said earlier in the talks, but I wanted to make sure we were all on the same page and in terms of definitions and what we mean by heart disease, as it can have many different aspects. So coronary artery disease or vascular disease, this is when we have buildup in the blood vessels supplying blood and oxygen to your heart, and it causes narrowing and blockages, and so there's impediment of blood flow. So from this, we can get heart attacks, chest pain, otherwise known as angina, if it's caused by the heart. And it's a major, as we saw, a major cause of disease burden and death in patients. Vascular disease is specifically the other blood vessels in the body. They're supplying blood and oxygen to the other organs. These can also get narrowed and blocked and cause effects. Heart rhythm disorders are arrhythmias. Those are when your heart is beating too slow or too fast or in a disorganized fashion. Structural heart disease is essentially what it says. The heart is a muscle. There are valves in the heart that direct the blood flow to move forward and to progress towards the rest of the body. And there are walls. There's a lot of different structures that can deteriorate and then cause issues for patients. And then finally, heart failure is a very serious condition that can be caused by the other conditions that I listed. It's the end stage of all of these if they're untreated or if they're very severe. And this is an issue that the heart is unable to pump enough blood around the body to meet the demands of the other organs. So this can be, as I said, the heart is a muscle. Heart muscles contract and they relax. So that means this can be caused if your heart is not contracting properly or if it's not relaxing because it is too stiff. So what is cardio-oncology? So cardio-oncology is a rapidly growing field, and it is a new field overall, but it is gaining a lot more awareness. It specifically looks to see in cancer patients, what are the effects particularly of cancer therapies, chemotherapy, radiation on the heart. The overarching goals are what I've listed here. So prevention of cardiovascular disease, which we do in every patient, regardless of whether they have heart disease or not. But prevention of cardiovascular disease, so managing blood pressure, diabetes, cholesterol, making sure that they're exercising. So that's the number one goal that we want for our patients. Prevention of cardiovascular toxicity. You can also hear the term cardiotoxicity. So that means when there is a treatment, chemotherapy or radiation that cause side effects on the heart and cause that cardiac toxicity. So we often get who are going to start chemotherapy or undergo radiation, that perhaps the oncologist feels under high risk of developing cardiotoxicity, and we'll refer those patients in order to help prevent it. Sometimes, however, despite everyone's best efforts, patients do develop cardiotoxicity. So at that point, we should focus in terms of how we manage cardiotoxicity. What medications are we going to start? What further tests do we need? How often are we going to be surveying patients and follow-ups? So this is up there just for information. I mentioned it briefly during the objectives. It is the 2022 European Society of Cardiology ESC guidelines in cardio-oncology. And this is mainly where we are using our information as cardio-oncologists in order to help us with prevention of cardiotoxicity in patients, but also in terms of how to manage cardiotoxicity in patients. And this very much depends on who the patient is, their risk profile, and also what type of treatments they're going to be undergoing, what type of chemotherapy regimens, and what type of radiation, and for how long. It also depends on what type of cancer they have. So this is taken from those guidelines, and this is what we do in every patient that comes into our clinic. We want to assess the baseline heart risk in these patients. And this is what we do. We use this wheel. I want to end at 6 o'clock on the wheel. So I'm going to start at 7 o'clock just so everyone can follow well. So if someone has had previous chemotherapy, for example, for a cancer, and they unfortunately have had a relapse or they've developed a new cancer years after they finished their chemotherapy and they need to undergo treatment again, they are at higher risk of having heart effects due to their new cancer therapies. So we see this in women who have had breast cancer therapies, have been in remission, but unfortunately have had a relapse and then need to undergo cancer therapy again. Prior cardiovascular disease, if we're moving up to 11 o'clock there. So that's when you've had a prior heart attack, you've had prior heart failure where your heart hasn't been pumping well. So that puts you at higher risk of developing, again, cardiotoxicity due to your therapies. Age, sex, and genetics, some family history, something that we cannot change, but are taken into account in assessing baseline cardiac risk. Then going over to about 2 o'clock, medical cardiovascular risk factors. So that is high blood pressure, cholesterol, diabetes, lifestyle risk factors. So smoking, alcohol, a sedentary lifestyle, how much exercise is the patient having, obesity, and also their weight category. So these are all very important, and diet is also very important in there as well. And finally, what we will do if we move on to 6 o'clock on our wheel, for all patients, regardless of their cardiac risk profile, we perform a certain number of tests. And this would be, it might be different for other people depending on what we see and depending on their symptoms and their physical exam. But these are baseline tests we would do in all patients. So one of them is an ECG. So that is an electrocardiogram, which many of you may be familiar with. So that's when we put stickers on your heart, we hook you up to a machine and we see what the electrical activity in your heart is. We also perform, there you see the acronym TTE, that stands for transthoracic echo. So that is an ultrasound of your heart that looks at your heart function, how the left side and right side of your heart are pumping, how the valves, the direct blood flow are doing. And we also do a number of blood tests, including cholesterol profiles, screen for diabetes, and also specific markers that look at the health of the heart in order to help us determine what risk category a patient is prior to starting their cancer therapies. So there's, as I mentioned earlier, there's different cancer therapies, and that is an extremely broad category, along with corresponding surveillance protocols. So based on those guidelines that we have, depending on the type of cancer therapy someone is on, it will dictate, even if everything is completely fine, their heart function is normal, even if they're low risk, how often we're going to be screening them with tests, how often we're going to be seeing them in clinic. Now, two of the most commonly prescribed chemotherapies in breast cancer patients, which some of you may have heard of, is one, anthracycline chemotherapy, which is one of the medications that's used in a combination of regimens for patients. And the other one is Herceptin therapy. So studies have been mainly based on these two treatments, looking at breast cancer in women. And these are often the main patients that we see in clinic. Of course, we see any patient who has cancer therapy and there's concern about their heart function. But in general, the population that's most frequently seen are females with breast cancer with these two therapies. And depending on the therapy and the risk profile, this will dictate how often we are following them and how often we're doing tests. Now, there is sometimes a concern prior to a patient starting their therapies that they are at higher risk, and we may have to start certain medications, such as a cholesterol pill and heart protective medications, in order to ensure their heart function does not deteriorate. If their heart function were to deteriorate during their cancer therapies, then we would have to adjust medications in order to help either stabilize their heart function or hopefully improve it. And we work very cancer physicians with the oncologists in order to determine the best course of regimen for patients. At times, it might mean that we have to switch cancer therapies or adjust it. And if we're unable to do that, then we work together with them in order to help protect the heart so that patients can receive the cancer therapies that they need, but still ensure that they have a healthy heart in order to be able to continue with treatment. Now, what's important, and people sometimes forget, is that even after we're done the chemotherapy for these patients, there is still a risk that these patients may have a deterioration in their heart function. So with anthracycline therapies, there is still a high risk even 1 year after finishing chemotherapy. With Herceptin, that risk can go out to 5 years. Now, late effects are very rare in patients, but it can happen. So who are the types of patients where we might need to see again? So those are the patients that have a second hit. A second hit could be all of a sudden they develop high blood pressure, they have a heart attack. This can affect patients that have received cancer therapies, even if throughout their treatment, their hearts were completely normal. This can this can cause a deterioration in their heart function because they received cancer therapies as opposed to somebody who hasn't. So it very much highlights what's been discussed already, the importance of annual cardiac risk factor surveillance, either through your cardiologist or through your family doctor, to check your blood pressure, check for diabetes, check your cholesterol, make sure you're a healthy weight. So what are some other sex differences in cardio-oncology? I've been talking about breast cancer, and obviously that's very common in females more so than males. And as I said, this is an area that we're trying to learn more about. So one thing that's very important for patients to always remember is that females do not always present the same way as males. So for example, if you're having a heart attack or you have angina, for males, we often think of that classic chest pain syndrome. And we think of that for females too, but female patients are more likely than males to present with shortness of breath, with fatigue, with dizziness, with neck pain or back pain. So these are symptoms that need to be considered in order to make the right diagnosis in patients. Heart failure presentation can vary between females and males. So we are seeing that a higher proportion of older females who are also more likely to be diagnosed with breast cancer are presenting with issues with the relaxation portion of their heart, with a stiff heart. And that is a harder diagnosis to make than when the heart muscle is not contracting properly. So it's very important, again, to take the entire clinical picture into account in order to make the proper diagnosis. And the treatment regimen is different. And thankfully, we have new medications that have been shown to help with treating symptoms and heart failure hospitalizations in this population. So it's important to make the right diagnosis so we can get our female patients on the proper heart failure therapy. Unfortunately, there is an underrepresentation of women in clinical trials, and we've seen this especially in heart failure trials. And this is something that's being recognized. And so we are having more studies that are highlighting the sex differences in patients. And there are some studies that are suggesting that perhaps female patients need different dosing regimens of their chemotherapy agents in order for treatment of cancer as opposed to male patients. There is also evidence that there's underutilization of therapies in female patients, which again is becoming more recognized and obviously an area that needs to be addressed further. As Dr. Amadio mentioned in her talk on pregnancy, we are recognizing the hormonal effects of women in cardio-oncology and the impact of pregnancy. Although it is quite rare for a pregnant woman to be diagnosed with cancer, it is possible. And it's an area where there are adjustments in terms of when cancer therapies can be done. And it puts the female at higher risk of having heart issues because of receiving cancer therapies. And of course, there's the question of menopause as well, and the hormonal changes that affect also your cardiac health risk. And finally, we have found that women are less likely to attend cardiac rehab programs that are of paramount importance. And a lot of this has to also do with socioeconomic factors. So in essence, we need more studies. We need more studies in order to see what further sex differences there are in cardio-oncology. And this is a field where they are calling for a gender-based approach to therapies for these patients. A lot of what we know from sex differences are taken from our heart failure trials and also from our heart disease, coronary heart disease trials, but more is needed. There's nothing specific in the ESC guidelines outside of pregnancy in pregnant patients with cancer and cardiac issues, but this is an area that will need to be addressed in the future. Young girls who have survived childhood cancers and have received anthracycline therapy, which I mentioned, have increased cardiotoxicity risk versus males. And this is a population who, as we are now having better life expectancy from cancer therapies because they are better, that needs to be followed and monitored by cardiologists. Postmenopausal women are at similar risk as men for cardiotoxicity. And again, especially in breast cancer, as most women are older when they are diagnosed, this is an important area that needs to be highlighted. So what do we tell our patients and what's important? And I know a lot of it has been covered already, but I think it just highlights how important this is. So exercise targets. So the goal, 150 minutes of cardio exercise, moderate to rigorous intensity per week. It doesn't have to be done all at once. It can be done 30 minutes, 5 days a week. It is the minimum target that one can be reaching, and moderate intensity can be brisk walking. No smoking, as I'm sure everyone's aware. Minimizing alcohol use. Health Canada has guidelines in terms of what low risk is considered for females and males. And perhaps many of you know that just recently in January, there was an article out that those limits have been drastically decreased. So it's important to minimize your alcohol use, not only for your heart health, but overall health as well. Healthy diet, and I often refer my patients to dietitians if they have questions. They are excellent healthcare professionals that really help to hone in on changes that can be made to diets. Sometimes we think that we are making healthy choices, and in fact, it might not be the case. So this is very important. blood pressure control, and I often tell my patients to have blood pressure machines at home. You don't have to measure it every day, but once a week or a few times a week, and recording the values is very important, and then bringing that to your physician's office. A lot of times the blood pressure that's at home is more appropriate, or more reflective, I should say, of what your actual blood pressure is, as opposed to the blood pressure that's measured in a hospital or clinic setting. And I do always remind my patients to take their blood pressure machine at least once a year to their doctor's office to have it calibrated to make sure that it is working properly. Cholesterol, which has been mentioned before, and diabetes, and not only monitoring this, but also being on appropriate treatment and meeting targets. Sleep health, and not only getting the recommended amount of sleep, easier said than done, I know that, but also if screening for sleep apnea is very important. And if a sleep study is recommended, and I know the management of sleep apnea is not always the most comfortable one, but it does very much help your heart health when your sleep apnea is properly managed. And finally, I always say patients, their families are part of the healthcare team as well. So it's important to share your symptoms, your concerns, to ask questions with your healthcare provider in order to find the right management strategy for you. So those are just a list of my references, and thank you very much. I'm looking forward to the Q&A session.
Thanks very much, Barbara. Again, I learned a lot there, and really these three talks really highlight the depth of expertise that we have at the Schulich program on women's heart health. So that concludes the formal presentations, and we're going to now begin with the question and answer portion of the evening. I'll reiterate that if you would like to submit a question, you can still do so. I'm going to go with some of the questions that have been provided beforehand. And the first was a topic that each of you did touch on in your talks, but it's probably worthwhile repeating it, maybe specifically in your areas of expertise. And the question is, how do symptoms of cardiac disease differ between men and women? And maybe I'll start with Dr. Madan. And Mina, if you could answer with regards to coronary disease and the kind of acute presentations. And then I'll look to Jennifer and Barbara to speak about heart function. And specifically, there have been quite a few questions about the stiff heart, which Barbara did talk about. And maybe if Jennifer and then Barbara, you could talk about what that is and what it means in your practice.
Thanks, Harindra. So if we talk specifically about heart attacks and just anginal type chest pain, so chest pain from the heart, there's been a lot of studies showing that there are differences between men and women. So when men have chest pain, let's say from a heart attack, they typically have central pain behind their breastbone. It might radiate to their jaw, to their back, down both arms, or maybe just down the left arm. So women also have all these symptoms of chest pain, but they also have other symptoms. So there's more to it. So they might have profound fatigue in the days preceding the event. They might have shortness of breath, palpitations, tingling, other additional symptoms. So it's important to have a high index of suspicion as physicians when we're evaluating patients, and consider doing tests, even though it might not be the most traditional presentation always.
Great, thanks. Jennifer?
Sure. I think, there are a few questions about what is a stiff heart and what causes the heart stiffness. So maybe I'll give it a try, and then Dr. Doumouras can give it a try too. But so I think the heart stiffness is the function of how the heart relaxes with time. There are many conditions that can impact how our heart relaxes. The stiffening of the heart can be caused by thickening of the heart muscle, or conditions that can cause thickening of the heart muscle, like having high blood pressure, where the heart has to pump against this high resistance and try to kind of increase its strength. And with time, just like any muscle lifting against a heavy weight, with time, the muscle can get bigger and thicker and stronger. But it also is harder for the heart muscle to relax when that happens. And so we also know that diastolic dysfunction, or the problem with heart muscle relaxing, can occur with patients as we get older. So it is kind of a common thing that we do see as patients get older. We see changes on their cardiac ultrasound or echocardiogram that are kind of consistent with this changes with time and with age, that the heart can become more stiff with time. In very rare cases, there are some specific things like abnormal deposits that can happen in the heart muscle that we're getting better at identifying now, such as cardiac amyloidosis, which is an abnormal protein that gets deposited in the heart muscle that can also make the heart stiff. I think when you're comparing women and men, we know that women traditionally have been more associated with having heart failure with this stiffened heart muscle, or heart failure with preserved ejection fraction, where the stiffened heart muscle that's hard to relax can cause fluid buildup in the lungs or in other parts of the body, and can cause symptoms such as breathlessness, having difficulty walking distances, feeling more short of breath, or trouble with retaining fluid or water in their swollen legs. And so those patients with this type of HFpEF, or heart failure with preserved ejection fraction, and this inability for the heart to relax can be quite challenging to manage. And sometimes those patients that have high blood pressure or have an irregular heartbeat kind of all go together with this syndrome. Fortunately, now we have new medications that can treat these population that have recently kind of been discovered and come to light. Before, we didn't have any medications that had been shown through clinical trial to improve patients' symptoms, their quality of life, prevent heart failure, hospitalization, and cardiovascular death. And so that's something new that we can start treating our patients with HFpEF with. And so that's kind of a new and exciting area. And we think that women may actually benefit more from some of these heart failure medications that we can use more so than men.
Maybe Barbara, if you wanted to add to that, but maybe something as simple as, why does the heart need to relax?
Yeah, so as I said, the heart's a muscle. So as with any muscle, if you think about when you're doing arm curls or whatnot, it contracts and it relaxes. So when the heart contracts, the blood pumps to the rest of the body. And when it relaxes, it helps fill the heart chambers with blood. So we need both. And unfortunately, both can be affected. Now, while Dr. Amadio went through a stiff heart or heart failure with preserved ejection fraction, we call it HFpEF for short, very well. So while we've very much recognized the issues with the contraction for many years, and there's a lot of medications that we have and regimens, we are just starting to recognize the effects of HFpEF. And it is a harder diagnosis, as I mentioned. Dr. Amadio went through that there are imaging parameters that we use to look at the relaxation of the heart to see if it's abnormal. But because it is harder to diagnose, it sometimes goes unrecognized. So that's why we really need to take into account the clinical presentation of the patient. So what symptoms are they having, their physical exam. Blood tests are very important, specifically heart markers that show us whether there's increased volume in the body, and also the imaging techniques, the ultrasound of the heart, as I mentioned. And Dr. Amadio went through why a stiff heart may occur. The risk factors that we see for patients that would be diagnosed as a stiff heart tend to be older, female patients more often than males. Also, patients who have coronary artery disease. So again, the blockages in the arteries that's supplying blood and oxygen to the heart. Atrial fibrillation, which you might have heard about, which is an abnormal heart rhythm where the heart's beating fast, is a risk factor. Obesity and increased weight are also all risk factors, and also sleep apnea. So all these taken together put one at increased risk of developing it. It's very important to recognize it, because now we do have therapies that can help patients stay out of hospital, so stay home. Feel better is always the goal. And a lot of it also has to do with maintaining lifestyle. So again, the smoking, the alcohol, also your healthy diet. So sodium restricting, not adding salt to your meals, and also fluid restricting is of paramount importance in these patients.
Great, thank you. Great answers from all of you. So this next question is a really important one. So we've heard about how heart disease presents differently in men and women. We've heard a bit concerningly that a lot of the studies that we have underrepresent women. And unfortunately, some of these conditions that affect more women than men in heart disease, although things are improving, still the number of therapies are pretty different, the therapies that are available for the conditions that affect men versus women. So the question from the audience is, how should a woman advocate for oneself with a provider in the emergency room or elsewhere if she suspects that she has a serious heart condition? So maybe I'll start with you, Barbara.
So as I mentioned, patients are part of the healthcare team as well, and you're at the center of the healthcare team. So it's important to share your concerns. And I understand sometimes that might be hard. Perhaps you don't have all the knowledge in order to articulate yourself well. So the most important thing to do is know your symptoms, know your body, tell people what is different. Sometimes it helps to also write things down. As I know, in an emergency department or in a hospital setting, there's a lot going on and it's a very stressful environment. It's good to have a family member there with you who can also help you with in terms of articulating things and share what they've been seeing with your healthcare trajectory. So I think the best way to do that is to advocate for yourself, to not be shy, to share what is going on with your body, what is different, how you were when you were healthy, when you didn't have symptoms, knowing how a patient was. If they say they've had a month-long period of chest pain, for example, and now they're not exercising as more, say, well, 2-3 months ago, this is what I was able to do, to very much highlight the differences in terms of not only your symptoms, but also in terms of your functional capacity. I think it's just important to advocate for yourself, because you are your greatest advocate.
Jennifer, what advice would you have?
Sure. Yeah, I think I would echo all of those great thoughts and advice. So you're right. The patient is the center of the healthcare team. So your provider should be listening to you and respecting your opinion and your symptoms. The clearer you can be about the new changes that you're experiencing, the more pieces of the puzzle we have to try to help you to put it together. I think really trying to get a clear record or thoughts about, when did this start? What am I actually experiencing? And as Dr. Doumouras said, what is the change in how I'm functioning and how is this impacting my life? I think those are some of the main things that can really help to tell your provider what has really changed and how we can do our best to try to help you and get back to the things that you were doing before. Sometimes you have other members within your healthcare team that can also help you to advocate, like a family physician or another trusted healthcare provider. And those are important individuals to go to as well, to try to make sure that you're getting to see the care providers that you need, or the specialists that you may need, or the tests that you may need to have to try to sort out exactly what's going on with you.
Mina, same question. Maybe I could also ask, over the arc of your career, Are things better, or are women still fighting an uphill battle for their cardiac symptoms to be noted by physicians and healthcare providers?
Yeah, I do see things improving. So a lot has been made in medical literature and in the lay public about the fact that women have a hard time being heard in emergency rooms, in their doctor's offices, their symptoms being equated with anxiety or panic. And I agree with the comments of my colleagues, like women are their best advocates. So if you think you are having a heart attack, then you need to go and express your concerns and at a minimum, make sure that an ECG is done. And maybe 1 or 2 ECGs are done and 1 or 2 blood levels looking for heart muscle damage, such as troponin. That's the blood test we use commonly nowadays. And 2 tests done about 2 to 3 hours apart should be able to clear up any concerns about your safety. So I do advocate for that, especially among patients who know they have a diagnosis of heart disease. And in the SCAD population, I tell them, go to the emergency room if you are having severe chest pain and tell the doctor, I had SCAD, I had a heart attack, and tell them what it is, because maybe they don't know what it is. And if they don't know, they can Google it just like anybody else. And get your ECG and your blood tests done to make sure that you're okay and you're safe to go home. And if you're not safe to go home, you'll be admitted and we'll take care of it from there. I think things are improving though over time, because I think the message is out there. So I think even physicians are changing their attitudes slowly, and also newer generations of physicians have different perspectives on patient-centered care. And I think that's really coming to the forefront nowadays. Certainly a big part of what we do in the Schulich Heart Program.
Wonderful answers from the 3 of you. So we have a couple of questions that are going to be about lifestyle and family history. So I believe one of you said family history is something you can't change, which is true. Can't change that. So the question is, if somebody does have a really strong family history, parents had heart disease and had poor outcomes, how can a person feel confident that there's hope, that they're not doomed to the same fate? What advice would you have for patients who come to you with that type of family history? Maybe Jennifer, I'll start with you, and then we'll ask Dr. Madan and Dr. Doumouras.
Sure, thank you. I think obviously, family history is an important factor that we consider when we're taking your overall health history, and we take that into consideration. Our genetic makeup comes from obviously both of our parents, and some conditions can run in families. However, not all events are completely passed on, and many of these conditions, especially for heart health, have many modifiable lifestyle factors as well. So I think it's not all doom and gloom with the family history. I think it's definitely a point to be aware of, to know your history, and try not to let history repeat itself by having good intervention, trying to stay as healthy as you can with your diet, your exercise routine, getting good checkups with your doctors, and monitoring yourself for any change in your symptoms. I think there are so many things that we're learning now, and so many new modifiable or changeable things about our health and our health history, and even our medications, that we didn't know, I think, 20 or 30 years ago. So it's, I think, always a combination of your genetic, but also your environmental factors. And so those kind of play together, and you, that's important to consider as well. That
Perfect. Thank you. Barbara or Mina, do you want to add to that?
Sure. I echo what Dr. Amadio said. I think lifestyle, we've been talking about prevention a lot, and that is the most important aspect. So I think the other part is knowing your family history well, knowing what caused, if somebody had a heart attack, at what age, if they had a sudden cardiac arrest where their heart stopped beating, knowing what age that happened, perhaps the cause of it, if they had been diagnosed with specific heart conditions, what specifically those were. I think that gives important information to the healthcare provider, as in certain conditions, they would do screening. So we have mentioned thickened hearts. So there is a condition called hypertrophic cardiomyopathy, which can put patients at increased risk of cardiac arrest. So that's when the heart muscle abnormally thickens, and it is known to run in families. So if you do have a history of that, for example, even if you are healthy and don't have any symptoms, we would suggest that you get an echo, an ultrasound of your heart, and an ECG for screening, for example, and perhaps even genetic testing. So it's easier said than done. I have a lot of patients that say, my mom had some heart issues. I don't know what they were exactly. And, that's fine and it happens. But the more information you have about your family history, ages, what kind of condition, when they were diagnosed, if they died and when they died, and not only in your parents or your siblings, but also first degree cousins, aunts and uncles, even grandparents. These are all very important information in order for us to determine whether somebody needs additional screening and interventions.
Yeah, I would add to all that's been said. If there is a prior family history, that's extremely helpful because it helps kind of determine when you might go to your physician to ask for screening, and you might go sooner if there's a very strong family history, let's say, of coronary artery disease. And then the things that the advice that was mentioned on I think both Jennifer and Barbara's slides was really helpful, like keeping healthy body weight, eating well, exercising regularly, blood pressure less than 135/85 at home, get screened for diabetes or cholesterol, when you're become an adult with your family doctor, even just to make sure that that's not in your profile. And there are young patients that I might be screening with stress testing every 5 years. Sorry about that. Every 5 years, in order to just make sure that they're not developing coronary artery disease. And there are other types of tests that we can do to look into things more deeply if there are concerning features when we do screen. So there are invasive angiograms. There are less invasive angiograms as well. Something called CT angiography that can also be very, very helpful. So
bottom line is be aware of your history, but don't feel resigned to it, that there's been a lot of progress, that screening, that things have improved a dramatic amount over the last many decades, and there are therapies available. So on the topic of prevention, we have quite a few questions about how much reassurance can people get from things like exercise. So if somebody has an elevated blood pressure, should they be taking pills right away? How much can they expect things to get better with diet and exercise? What's the advice that you give your patients? Mina, start with you.
Sure. We are, I have an interest in high blood pressure management, and certainly the cornerstone of treatment of high blood pressure is to start with simpler things, and maybe not so simple to lose weight, but eat well, low salt diet, less than 2 grams per day, and regular physical activity. And that helps a lot of patients who might be borderline. I would give that at least a good 6 months to try and see if a trial of this will work to help control blood pressure, and a meaningful reduction, maybe even a 5% reduction in body weight, can go a long way to improving blood pressure control and even blood sugar control for that matter. So we always start with the lifestyle things that can be addressed, but sometimes patients do need a little bit of medication to help them.
Maybe I can just ask a quick follow-up on that, because you do have an interest in blood pressure. So unlike your cholesterol, which is a blood test and you get a number from the lab, can you tell the audience about blood pressure measurement and how complicated?
Sure. Yes, so we generally recommend a very systematic approach to taking blood pressure. So we recommend first thing in the morning before any medications when you get up. And we also recommend in the evening after meals, and keeping a blood pressure diary of the morning and evening blood pressure. Patients, we say, should be seated with their arm preferably on a table or by their side when they're measuring the blood pressure. And at home, like in the office, we take the average of 6 readings, but at minimum of 3 readings, and taking the average of the 3 readings at one setting, because blood pressure usually starts out higher and then gradually comes down with successive readings. So we usually tell patients to average the 3 readings to get a more representative sample. And certainly it's normal for blood pressure to fluctuate from moment to moment throughout the day. But systematically recording it is a good start.
Really important advice. And I think Dr. Doumouras mentioned about having a home blood pressure tool at home, and having that diary and taking real ownership of it yourself is important before you get labeled with high blood pressure. Jennifer, what do you tell your patients about lifestyle and medications? How much time do you give them?
I think I'd probably do something similar, where we give a trial of period to have the lifestyle modifications, since we know that those are so powerful and obviously can have the most impact on your health as well. I think about 6 months is probably a good time period. You don't want to let it go too long when you keep coming back and then you see another 6 months, the years can drag on, and then you are not treating this problem, which can become a silent killer, right? Of the high blood pressure that's not maintained, that can cause a lot of arterial disease. Sorry, my lights turned off in here. So yeah, I think that's a good trial period to see if you can get some of those lifestyle interventions can have an effect on your blood pressure. And as we know, blood pressure does vary from moment to moment throughout the day, or depending on the stress that we're experiencing in our life or other factors that can be going on. And so having a good trial of those things, and also looking into having the opportunity to look into some other conditions, as Dr. Doumouras said, like having a sleep study if we are suspecting that patients have sleep apnea, which can also cause high blood pressure, and could be reversible without medications. So there are a few things that we should look into beforehand.
Barbara, I'll ask you the same question, but not about blood pressure, but about cholesterol. The other thing that many of us get screened about and get worried about. What do you advise patients as far as diet and lifestyle changes, and when should they go on medications?
Yeah, so in terms of when to go on medications, it does also depend. If somebody has had a heart attack, for example, we would strongly recommend that they go on cholesterol lowering therapy, even if their levels are okay. In terms of, if I speak generally in terms of lifestyle, so again, it gets back to diet. So mostly diet fruits and vegetables, eating healthy meats, so lean meats like fish and chicken, and then also decreasing your salt intake, as was mentioned before, less than 2 grams a day is important, and minimizing your artificial sugars and your desserts and junk food, which I know sometimes it's easier said than done. But trying to minimize all those unhealthy meals, or even eliminating them from your diet. And as I said during the talk, a referral to a dietitian is an excellent way to even find out foods that you think are healthy may in fact not be. And it's a great way to have that conversation with an expert in that area. In terms of other things, again, it's exercise. So not being sedentary and getting at least your target level in order to help decrease your cholesterol. Not smoking, decreasing your alcohol use are very important as well. And sometimes, despite our best efforts, you still would warrant a cholesterol therapy. In general, cholesterol treatments are well tolerated by most patients. As with any medication, there are side effects to that, but obviously that's something we would monitor and then adjust therapy or change the medication if needed, but it is very important to have it under control.
Perfect. Great advice from all of you. So we've got a couple of tougher questions to end the evening. But they are questions that are related to our topic of women's health. So there's a question about POTS, and I'm not sure who to ask because it's a tough question, but a question about perhaps what is POTS? Does it affect women more than men? And is it something that only young people get? So who wants to take a shot at that? And if nobody feels oh, perfect.
Sure, I'll try. So females are females are more affected than males. In general, it is 15 to 50-year-olds that we see, but it can rarely affect individuals who are above the age of 50, although yes, we don't see it as much. In terms of the symptoms of that, so you'll hear the word orthostatic. So that's when we are in a lying down or seated position and we stand up and we have symptoms of dizziness, or you might feel your heart beating loudly. And the way in order to diagnose it, although it's not always the easiest diagnosis to make, is basically correlating symptoms after you are from a lying down or seated position and you stand up and looking at the change in heart rate during that time. So that's the main way. But yes, well, most people are diagnosed between the age of 15 to 50. Rarely we may see it in older individuals. The issue with as we age, there are other reasons that we might be having those changes in terms of our symptoms when we stand from a seated position. So that's why it might also make the diagnosis harder to make. But do
you want to just tell the audience what POTS is? It's a funny acronym.
Oh, yes, of course. So that stands for postural tachycardia syndrome, short for POTS.
Perfect. And an interesting kind of side note is that I guess one of the traditional ways of making the diagnosis or helping is a tilt table, where you put a patient on a table and you kind of put them upside down a little bit. And for whatever reason, that has fallen out of favor as a test. And we are actually the only site in the city, for sure, and I suspect most of the province, that continues to actually do that test. And we do it 5 to 10 times a week. I'm not sure how many times we're diagnosing POTS with it, but it certainly is a test that's done frequently at our place. So there've been a few questions about the different types of tests that are available. I know Dr. Madan commented on it doesn't have to be angiograms, that there's special tests like coronary angiography done through CT. Maybe I'll ask, there's a question of when is a stress test warranted? And some people have commented that they get stress tests every year. So what is a question I'm sure your patients ask you? How do you answer that? Mina?
Yeah, sure. So that's a pretty fair question. We talked about already one circumstance where patients have a family history of coronary artery disease. So screening for disease is certainly warranted, probably in certain people who might have family history. Also, some patients may come to us with symptoms, so we are doing it for making that first diagnosis. So if someone is having symptoms, I exert myself, I get chest pressure, squeezing, tightness in my chest, I rest, it goes away. Pretty classic symptoms. And sometimes the symptoms aren't so classic, and we're just wondering because it's in the realm of possibilities for a patient's symptoms that they come seeking help for. So then we might do a stress test. And there are different types of stress tests. Some are done just with a plain treadmill, others are combined with echocardiography or nuclear imaging. We also might use stress testing to assess the impact of treatments that we've done on the circulatory system of the heart, or even the structural parts of the heart, and see if those treatments are working. So patients who've had stenting done, maybe every 3 to 5 years, I might just test them out of the blue to check and see, are you okay? And sometimes we pick up things, often we don't, but that's another helpful way to assess and follow along patients over their lifespan.
Great. Now, although I didn't say this on her introduction, Dr. Amadio is also, from her imaging, an expert in how we address some of the valves of the heart. So there's a question about mitral valve disease and prolapse. And so maybe, Jennifer, you could speak about what that is. Does it affect women more than men? And does it require people to check on it yearly? And how does it kind of get worse? So a few bunch of questions there.
Sure. Okay, no problem. I think so mitral valve disease. So the mitral valve is one of the valves that sits on the left side of the heart that lets blood flow in from the left atrium or from the lungs into the left atrium out to the main pumping chamber of the heart, the left ventricle. And the valve in your heart is kind of like a little door that lets the blood through and closes so that the blood can't go backwards while the heart is pumping blood out to the body. So mitral valve prolapse is when one of the leaflets of the valve bends back or can bow backwards. And sometimes it can be something that we're born with, a structural abnormality of the heart, and some people are more predisposed to that than others. It does tend to affect women more than men. I think in the past, mitral valve prolapse was very frequently diagnosed based on our older imaging techniques. Now, with newer versions of echocardiography or ultrasound of the heart, we're finding that maybe some of those people that had mitral valve prolapse didn't in fact have it after all. We characterize mitral valve prolapse as having the valve bowing back more than 2 millimeters on our imaging from the mitral valve plane. So this condition can sometimes be associated with leakiness of the heart valve, and it can sometimes be associated with the heart murmur that your doctor may pick up on the examination when they're listening to your heart with their stethoscope. And so it can trigger sometimes an ultrasound of the heart so we can get a better look at what's going on. Usually I tell my patients that we do monitoring of this condition, I'd say every 3 to 5 years for a stable patient. If there is significant leakiness of the valve, then we may do the imaging more frequently to kind of check on you. And we always watch what the symptoms are. Things you can do to try to reduce the complication or a problem from this. Many people live with this condition and have no trouble with for many years, is to have good control over the blood pressure and to do all of those other lifestyle modifications that we've been talking about this whole time. Make it easy for the heart to pump and relax, and keep good control over all of those things. So it's a condition that we do see, and we follow it accordingly.
Great, thank you. This is another question for you, Jennifer, and that's how do you assess the safety of continuation of some cardiac medications such as antiarrhythmics during pregnancy? So can you kind of comment on where patients can get that type of information, and if they're worried, what they should do, what your advice would be for them?
Yeah, I think the best thing to do is to speak to your provider in that kind of early pre-planning conception phase, if possible, or as soon as you find out that you've become pregnant, to try to identify those medications that may be at a higher risk to you or your baby, and to try to optimize the medicines as much as we can. There are some guidelines that we have in Cardio-Obstetrics about certain medications that have more studies on them that have been shown to be safer in pregnancy. And so your provider would help to kind of coordinate that with you and your medical condition. Some medications can be changed or withdrawn depending on how stable your medical condition is, or what the treatment of them, what we're treating with them. So I think it's a two-way conversation with you and your medical provider, your obstetrician, your cardiologist, or your general practitioner. But I guess the best advice is to try to look at the medications you're on in that kind of pre-planning phase.
Perfect. Thank you. That's great advice. And I'm going to ask Dr. Madan a question, because she does put stents in. That's one of the many hats that she wears, and she's the director of our cath lab. So what advice do you tell patients in 2023? Because there's been so much change with stents, about how often do stents become blocked, and what patients need to do to know if their stent is getting blocked. Do they need to have regular angiograms, for example? Anything that extreme?
Sure. So over my career, we've seen dramatic improvement in stent technology. And now what really was a game changer in stent technology was the application of drugs to the stents themselves. Then the drug would prevent in-stent narrowing over time. And the drugs that are coating stents nowadays, which makes up pretty much nearly 100% of the stents that are put in, because that's the best technology available, the drug comes off usually for most of these stents in the first month into the wall of the artery. And what that drug does is actually reduce the chance of re-narrowing of stents. So used to be, before we had drug-coated stents, back 20 years ago even, or 15 years ago, the rates of re-narrowing in general were about 10 to 15% after a stent. If you had certain types of blockages, long blockages, you had diabetes as a patient, you had maybe a bypass that was being stented, something fancy, a tricky area calcified, it would be higher, in the order of 25 to 30% chance that the stent would fail, and we'd have to do repeat procedures. And the more we do more repeat procedures, the harder it becomes to keep these stents open. So drug-coated stents have changed it so that across the board, regardless of the type of narrowing that's being treated, the chance of re-narrowing is less than than 5% in general. It's really, really low. It's not zero, but it's quite a bit lower than it was. So what do I tell patients on what to do, how to know? If I tell them to use their stents, so I tell them to stay active. In most cases, the patients find the problem before we do. I tell patients, when I see them in the office, we're going to do a stress test next year, but that's just a goalpost or a milestone. If something changes before then, if your symptoms come back, you need to be in touch with your doctor to let them know so that more screening can be done and the plans can be changed. Plans are flexible. And I really think patients often know come to know what angina feels like, what a heart attack felt like. And sometimes they experience their angina during the procedure when we're blowing up the balloon in their coronary arteries and implanting the stent. They say, oh, that feels funny. What is that? That's what I was having before. And we say, that's angina. Remember that sensation because that's what you need to look out for. So.
Great advice. So that gets us to the conclusion of our Q&As. I'd really like to thank Dr. Doumouras, Dr. Amadio, and Dr. Madan for their excellent presentations. I hope the audience got a sense of the depth of their expertise in the things that they spoke about with regards to women's health in their presentations, but also the breadth of their cardiology knowledge with the questions that they answered, really, which really covered the entire waterfront of cardiac disease. A few more points before we wrap up for the evening. Please take a moment to fill out the electronic evaluation form. That'll really help us with planning future talks and topics for you. You can add your name to our mailing list for future talks. I'd like to thank Carrie from our board for providing the introductions and kicking off this evening. And a big thank you to all of you for joining us for this discussion. So please be sure to check out upcoming topics, which will be shared on our speaker series website